This video is going to be on muscular pathologies, and we'll start our talk with muscular dystrophies. Muscular dystrophies. Now, muscular means muscles, dystrophies means wasting away. So these are inherited disorders that cause your muscles to waste away. Waste away. Now, the main ones we're going to talk about today are going to be Duchenne's and Becker's. And like I said, it's inherited. So the inheritance patterns of these both are going to be X-linked recessive. And the last one is myotonic dystrophy. Inheritance pattern of this is autosomal dominant. Now, Duchenne's we'll talk about first. Duchenne's is a problem with dystrophin. Dystrophin. What the heck is dystrophin? Dystrophin is a giant protein that links your muscle cell to the outside. And you need that, otherwise your muscle cell is just kind of free flowing. We don't want that. So dystrophin links your muscle cell to the outside. And it does this because it binds to myofilaments like actin. We talked about actin in our previous video. That's one of the myofilaments. So it binds to actin and then it kind of links it to the outside. And if your body doesn't have dystrophin, then it can't link to your outside. Your muscle cells kind of degrade and they'll die. And that causes wasting. The gene that codes for it is actually the longest gene that we have. So you can imagine it's prone to mutations. So all right, prone to mutations. Prone, that's not how you spell prone. Prone to mutations. Now, what are the types of mutations? I didn't think I'd throw that at you. What are the types of mutations? You have missense, nonsense, frameshift, all those types. So if you're weak on genetics, that's an easy way to can turn something that's simple and turn into a genetic question. So what are the types of mutations? Hopefully you remember. What's the worst type of mutation? It'd be your frameshift. Frameshift. Recall that's the insertion or deletion of a nucleotide that causes the whole reading frame of that gene to kind of shift. So that mutation causes misreading of everything downstream. That is the most dangerous mutation. And when you have a frame shift, then you'll have mutated dystrophin. Could be truncated, could be mutated. It's just not a good look. So frame shift mutation. Where sometimes, well, the baby will inherit this, so they're going to start having muscle wasting in the early stages of their life. However, it becomes really apparent when they're 1 year old. Why is that? Well, when you're 1 year old, you're going to start trying to learn how to walk. And so if you have weak muscles, then any kind of abnormality will become very apparent when you're trying to walk. So babies will have difficulty walking. They have difficulty standing because their calf muscle basically has wasted away. That calf muscle gets replaced by fat. So I'll say calves replaced by fat. And it looks like their calves are huge, like they've been working out, like they've been having muscle hypertrophy, but it's not. It's actually fat replacement. So we call that pseudo-hypertrophy, which is fat replacement. Eventually, they find it very difficult to stand. If you lay them down and ask them to get up, usually we can just kind of get up on our own with the power of our feet and our arms. But they have to lie prone and kind of tent and TP themselves up and kind of walk up with their hands. I have a picture in my notes if I don't describe it correctly. But important you know that. That's called the Gowers sign. Gowers sign. Now these are all skeletal muscles, but that's not the only type of muscle you have. You can have smooth muscle, you can have cardiac muscle involvement. That's not good. Anyone that has problems with their muscle wasting will have problems with their cardiac muscle wasting. Cardiac muscle isn't immune to this, so you're gonna have cardiac problems. All patients are gonna have cardiac muscle problems. And cardiac muscle involvement, we call that cardiomyopathy, myo meaning muscle, and that's usually how they eventually pass away. So cardiac involvement, don't just think skeletal muscle. So these are some very clear clinical physical exam findings. How about laboratory findings? Well, we're going to have elevated CK and aldolase. These are not specific enzymes to your muscles. They're found in a lot of places, but seen more heavily in your muscles. And so when your muscles die, they release creatine kinase and aldolase. Let's look for something more specific. Well, the more specific thing you can do is you can biopsy the muscle. Biopsy. And instead of the muscle, you're going to see that fat replacement. So you're going to see a lot of fatty replacement. And probably the most specific sign will be looking for that protein. Look for mutated dystrophin. We can use a blot to do that. I'm throwing a lot of biochem and genetics to you. So what blots look for proteins? Is it a southern blot? Is it a northern blot? It's the western blot. So western blot. Western. All right, that's Duchenne's. That's a frameshift mutation in your dystrophin gene. What happens if you don't have a frameshift mutation? What happens if you have a milder mutation? If you have a milder mutation, then you have a milder mutated dystrophin, and you can kind of have a milder form of this disease. We call that Becker's. That does it for Duchenne's and Becker's. Let's move on to myotonic dystrophy. Dystrophy means wasting of muscle. Myotonic means unable to relax. This is an inherited disorder. That's the name of the game. Of trinucleotide repeats. You get a ton of CTG repeats in the DMPK gene. You need to know it's a trinucleotide repeat of CTG. There's only a handful of trinucleotide repeat disorders, so you need to know them all. So there's a trinucleotide repeat of CTG. And it mutates this gene, and this gene codes for an enzyme that's found in your muscle called myotonic dystrophy protein kinase. So myotonic dystrophy protein kinase. A protein kinase that causes myotonic dystrophy is mutated. So it mutates that protein, and then you get myotonic dystrophy. What are some signs of myotonic dystrophy? It's actually a multi-system disease, so it doesn't only affect your muscles. Some physical signs you can pick up right away is frontal balding, cataracts is seen in almost 100% of these patients. Why it causes cataracts, I'm not quite sure. But you gotta know cataracts, frontal balding, testicular atrophy. Just to show that it's a multi-system disorder. But this video isn't about all this stuff. This video is about muscle. So what are some signs that show there's muscle dysfunction? Why is it called myotonic again? Myotonic means unable to release. So these patients will be unable to relax. The classic finding is someone that swings a golf club and can't release the golf club, so they're just holding the golf club. Or they'll shake your hand and they can't release their hand. Or they'll open the door and they can't release the door handle. They're unable to relax. We call that myotonia or myotonic, from whence it gets its name. You can also have signs of wasting, that's the name of the game, and then heart involvement. This time usually in the form of arrhythmias, heart block. That is myotonic dystrophy. A clever question I got on myotonic dystrophy. They were talking about all the signs. So a patient comes in, shows frontal balding, bilateral cataracts, shakes your hand and is unable to let go. So you know right away it's myotonic dystrophy. And then they can ask you a whole host of like genetic questions. So they can ask what genes mutated, or what kind of proteins mutated, or what's the main cause, trinucleotide repeats. Or the more clever way to ask it is they'll give you all the signs and then say, this disorder is similar to what other disorder? And they'll give you all the answers and look for any other trinucleotide repeats. So Fragile X syndrome, you can have Huntington's. So all the trinucleotide repeats, you gotta know code. Okay? That does it for muscular dystrophies. And we're gonna finish this video off by talking about the neuromuscular junction. What the heck is a neuromuscular junction? Do you recall the main function of your muscles is to contract, right? Let's just recap that shortly. So you have your muscle, so your myocyte, And we have our contractile unit, and we said our sarcoplasmic reticulum kind of covers it, and that your membrane invaginates and creates a T-tubule. And these two kind of talk with each other. The sarcoplasmic reticulum kind of talks to the T-tubule via the dihydropyridine ryanidine receptors. So that's your muscle cell. Now, how do we cause contraction in the first place? Well, we had a nerve, right? A neuron that released acetylcholine, and that acetylcholine eventually bound to the acetylcholine receptors on the muscle cell, and that causes depolarization. That dipole went down the T-tubule, talked to your sarcoplasmic reticulum, and you release calcium, cause contraction. That was how we talked about contraction, and I kind of skipped over a very important part. I kind of skipped over the initial step. Without that initial step, without that neuron releasing acetylcholine, then you don't have muscle contraction. Yeah? So this whole step is very important. Let's just kind of blow it up and magnify it a little bit. So we have our neuron that eventually needs to release acetylcholine onto the muscle cell. This is called the neuromuscular junction. The junction between the neuron and the muscle cell. And the space in between is sometimes called the synapse. And so in the space above the synapse, we call that presynaptic, so that's where your nerve is. Below the synapse, we call that postsynaptic, that's where your muscle cell is. So let's see how this works. If I want to move my thumb, then I send a nerve impulse to the nerve, causing depolarization, and I get to move my thumb. So I send that nerve impulse as an action potential, and it goes down to that nerve. And when that action potential hits that nerve, it causes voltage gated calcium channels to open. Calcium influxes, and that calcium influx causes your vesicles full of acetylcholine to release. Here's your acetylcholine. That eventually hits your acetylcholine receptor and causes your muscle to contract. Acetylcholine eventually gets degraded by acetylcholine esterase. That is how you cause that initial contraction. So what can go wrong? You can have two disorders. You can have Myasthenia Gravis. Myasthenia just means fatigue. Gravis means grave or serious. So this is serious fatigue. Serious fatigue. Not just regular fatigue, serious fatigue. Second is Lambert-Eaton myasthenia syndrome. Let's talk about myasthenia gravis first. So my gravis is due to autoimmune antibodies against the ACH receptors. So these antibodies come in and bind these receptors. I'll just draw a little bit more of them. Come in, bind these receptors, and can destroy these receptors. What do you think will happen if we destroy those receptors? You're not going to elicit that depolarization of your muscle, so you're not going to have muscle contraction. So your muscles won't contract, and you get this weakness, this fatigue. That's the name of the game, serious fatigue. Often affects the face and the eyes. So you can get diplopia. You can have ptosis, so drooping of the eyelids. You start to see double, blurry vision. And it's very important because a lot of muscular disorders spares the eyes. These are smaller muscles, so it kind of spares them. Even ALS spares the eyes. So anything that deals with the eyes, really pay attention to that. And a dead giveaway in history is that patients will feel worse with use or over time or even over the course of their day. So they might wake up and feel fine, and then at the end of the day, their eyes get a little droopy. There might be diplopia. They might feel more fatigued. Classic finding in myasthenia gravis. Why do they get that? Well, eventually, all those receptors will get destroyed or binded to. And you just get more and more fatigued as the time goes on. Understand? Very important. I'm gonna put 2 stars. So know that history clue well. So a patient comes in with all those clues. You can do some further testing. You can just put an ice pack on their eye if they're having ptosis or double vision. And cold temperatures just make this junction work a little bit better. And so they can have symptom relief once you relieve that ice pack. That's a little bit less science-y. So we try and be a little bit more science-y here. So we give a drug called endrophonium. Endrophonium blocks acetylcholine esterase. And by blocking that degradation, then you have more acetylcholine building up. And it'll be able to bind whatever few receptors you have left. And so that kind of resolves the symptoms also. So if this resolves symptoms, so alright, acetylcholine esterase inhibitor, if that resolves symptoms, then you're thinking of myasthenia gravis. And probably the most specific test you can do is just basically look for those antibodies against your acetylcholine receptor. So look for antibodies. That's probably the most specific test you can do. Where do those antibodies even come from? A lot of times they come from your thymus, especially if you have a thymic cancer, a thymoma. I've seen this great question talking about a person coming in. They're complaining that by the end of their day, their eyelids are just droopy and they can't seem to open their eyelids. They're seeing blur, double vision, having blurry vision, feeling fatigued. And then right at the end, they'll ask, what additional tests are you going to order? And I looked for antibody findings, looked for endrophonium, and it wasn't there. Instead, what they're looking for is CT of the chest, looking for that thymoma. Oh, that's clever. So you're going to look for that thymoma. And if the antibodies are coming from that thymoma, then treatment, take that thymoma out. And that can actually cure them. So remove thymoma or thymectomy. If it's not coming from that thymoma, then it's coming from somewhere else. Sometimes you don't really know where it's coming from. So you try and at least slow the progression. We can slow the progression by giving immunosuppressants or a long-acting acetylcholine esterase inhibitor to kind of build up that acetylcholine. Our favorite is going to be your pyridostigmine. Seen a lot of questions on that also, so know that's kind of our drug to slow the progression of Myasthenia gravis. Let's talk about our next one. Our next one is Lambert-Eaton. This again is another autoimmune disorder causing antibodies against something. Antibodies against, what is it? Waiting on bated breath. Antibodies against your presynaptic calcium channel. So it binds and obliterates that calcium channel. And without calcium influx, then you don't release acetylcholine in the first place. So reduce acetylcholine release. And that won't bind to your receptors. It won't cause that depolarization and muscle contraction. So this causes weakness. However, this one doesn't usually affect the face, doesn't usually affect the eyes. It affects proximal muscles. So like your arms and your legs. So people might have trouble getting out of their chair or walking upstairs. Proximal signs. And the dead giveaway is that it gets better with use. Why are they so lucky? Because if you use more, then you send more impulses and you will eventually get whatever calcium to influx. And that will release acetylcholine just by brute force, yeah? So it gets better with use. Now, where are those antibodies coming from? We said Maya comes from your thymus. This usually comes from a cancer. So we call this paraneoplastic. Comes from a cancer, paraneoplastic. The most commonly associated cancer is small cell lung cancer. And if you treat the underlying cancer, you can usually treat Lambert-Eaton. Here's the thing, hopefully you've learned by now. Don't just memorize associations. Tell me everything you know about that association and synthesize it into a step-like question. So what do you know about small cell lung cancer? If you say it's a lung cancer, that's not good enough. If you say it's a central lung cancer made of neuroendocrine cells, you're getting there. If you say it's a central lung cancer made of neuroendocrine cells, oftentimes see LMYC, oncogene amplification, chromogranin A positive, neuron-specific enolase positive, then we're getting somewhere, okay? So that's how you gotta think, and if you're not thinking like that, it's all right. We have a lot of time, a lot of more blocks to get through this, but develop that way of thinking, all right? Now synthesize it all into a step-like question. So a patient comes in coughing, weight loss, hemoptysis, also says, "Doc, I'm having trouble getting out of my chair." And you ask, well, at the end of the day, does it get better or worse? It actually gets kind of better. You do a chest x-ray, you see a mass. What tumor marker would you see in that mass? Things like chromogranin A, neuron-specific enolase, etc. So that's how we can incorporate all we've learned into a step-like question. That's how you gotta think. And if you think like that, it makes the step a lot easier. All right, that does it for muscular pathology. Hope you enjoyed the video. Thanks.